Okay students, so what we had seen the structure of kidney and the formation of urine in different steps. Now this formation of urine and the function of kidney is basically regulated. So previously also we had seen that it was regulated by auto regulation of the kidney, right? But now this will be regulated by different other factors as well. So let us see the regulation of the kidney function. The first method of regulating the kidney function is it can be controlled by the ADH, that is antidiuretic hormone. So it's a hormone which is responsible for preventing the water loss. It is responsible for preventing the water loss. Antidiuretic, what does it mean? Diuresis. Diuresis is a process of removal of urine from the body. What is diuresis? Diuresis is a process of removal of urine from the body. Now this hormone is responsible for preventing this removal, and you can say it is antidiuresis in nature. So it will be antidiuretic hormone. Now this ADH is mainly produced by the hypothalamus. It is produced by the hypothalamus which is present in our brain, okay, and released into the blood through the pituitary gland. So mind it is produced in hypothalamus but released into the blood through the pituitary gland. Now this is mainly responsible for enhancing the fluid retention by making the kidneys reabsorb more water. So it will be preventing the water loss, and it will be also reabsorbing the water from the kidney from the blood, so that the water is prevented, water loss is prevented. Now how does this function? So there are some specific receptors present on the hypothalamus region which are called as osmoreceptors. Now these osmoreceptors are the sensory cells which will be sensing the concentration of the solids in the blood, we can say. So if the osmolarity of the blood increases from the 300, then it will release the ADH into the blood. So the normal concentration should be at around 300, but if it is increasing, if it is decreasing, so it has to be taken care by regulation. Okay, so when it is increasing, the more than 300, the osmolarity concentration increases more than 300. It means that the blood has got higher concentration of the solutes. It means the blood has got higher concentration of solutes, or we can say the blood is concentrated. So and when the blood is concentrated, so the volume of the blood will be decreased. And pressure of the blood will also decreases. Okay, so to increase the pressure, to restore the pressure, and to restore the volume, and to restore the volume concentration, proper concentration, what will happen? The ADH will be released. Once this ADH releases, ADH will be increasing the blood pressure mainly by two ways. The first of all, it will prevent the water loss, and second, it will reabsorb the water from the body fluid. Or we can say it will retain the water from the body fluid. Okay, and third one, it will promote the thirst. So the body can consume more water. Okay, so these are the ways how this ADH will be responsible for increasing the pressure. Okay, so when the person is drinking the water, the drinking water will reduce the osmolarity of the blood, and when the osmolarity of blood will reduce, what will happen? It will inhibit the secretion of ADH, and thereby completing the whole feedback circuit. Okay, so the ADH will be retaining the water, will be reabsorbing the water, and will be promoting the thirst, so that person will drink more water. Okay, so next regulation is by JGA, that is juxtaglomerular apparatus. Okay, now juxtaglomerular apparatus is the one which will be retaining the sodium ions in high concentration. It will be responsible for retaining the high concentration of sodium ions in interstitial fluid. Okay, and this will be functioning in a particular system. It's a multi-hormonal system called as renin angiotensin aldosterone system, that is RAS. So this JGA will be operating in a multi-hormonal system, that is renin angiotensin aldosterone system, which consists of three different hormones. That is renin. It can be considered as an enzyme as well. The second is the angiotensin, and the third one is aldosterone. This all three together will be functioning, or will be regulating this function of maintaining the osmoregulation. Okay. Now the JGA, how does it function? So it will be whenever the blood pressure is decreased, when the blood pressure or the blood volume is decreased. So when the blood pressure, the blood volume is decreased, so during this process, this pressure decrease or the volume decreases, the afferent arteriole of the glomerulus. So when the blood volume or the blood pressure of the afferent arteriole of glomerulus decreases, the JGA will release an enzyme. The JGA will release an enzyme, that is renin. Now keep in mind, this renin is different from the renin which we studied in the digestion. In the digestion it was RENNIN renin that was responsible for digestion of proteins, mainly the milk proteins in the young child. Okay, but over here it is RENIN that's responsible for, it's basically related to renal, it means kidney. So here it is basically which is secreted from the renal, that is secreted from kidney, hence it is called as renin. Okay, so it will be secreted through JGA by JGA into the bloodstream. Now this renin will be initiating the chemical reactions. So here you can see, so when the pressure is low, this kidney, the JGA part of the kidney will be secreting this renin. The JGA part of the kidney will be secreting renin. Okay, and the JGA part of kidney will be secreting renin, and this will be responsible for converting angiotensinogen, that is an inactive hormone, into angiotensin, that is active hormone. So it is initiating this chemical reaction. Now this angiotensin will be converted into again angiotensin 2. This angiotensin 2 is the one of the most potent vasopressor known. It is the one of the most potent vasopressor known. It means it can constrict the blood vessels. And hence it can increase the pressure. Okay, so we can see the glomerulus release an enzyme, that is renin. The JGA release an enzyme, that is renin, into bloodstream. This renin initiates a chemical reaction that convert the plasma protein angiotensinogen to a peptide, that is angiotensin 2, which works as a hormone. Angiotensin 2 is powerful constrictor of arterioles, one of the most potent vasopressor substance known. Angiotensin 2 increases the blood pressure by causing arterioles to constrict. This is what we have seen. Okay, now it also increases the blood pressure by two ways. Volume by two ways. So first of all, it signals the PCT, that's proximal convoluted tubule. It signals the PCT to reabsorb more NaCl and water. It signals the PCT to reabsorb more and more NaCl and water. And it also stimulates the adrenal gland. It also stimulates the adrenal gland to release aldosterone. Now, what does aldosterone do? Aldosterone the aldosterone will induce the distal convoluted tubule, that is DCT. You know what is DCT, right? So aldosterone will induce the DCT tube to reabsorb more Na and water. So both it will be signaling the PCT, that is proximal convoluted tubule, to absorb more NaCl and water, while to the DCT it will be stimulated by the aldosterone. Okay, so it will be responsible for absorption of water by DCT and Na. Okay, because of absorption of more water, what will happen? The amount of water will be high in the blood, due to which the volume of blood will increase, and as the volume of blood will increase, the volume of the pressure of blood will also increase, and hence the blood pressure will be restored. So this is how it will be regulating the blood pressure. Okay, next, one more factor is there, that is ANF, that is atrial natriuretic factor. This is a factor which is opposing the regulation of RAS. Okay, so how does it do? So this atrial natriuretic factor is basically secreted by the atria. That's the wall of the atria of heart. We know the heart structure. The heart structure has got the atrial wall. So the wall of atria will be releases this ANF in response to the increase in blood volume and blood pressure. So when suppose the blood pressure is high, so this has to be opposed. This has to be regulated. Otherwise, the high blood pressure may also causes different type of problems. Okay, it may lead to the problems in heart particularly. So whenever the blood pressure is high, it is sensed by some cells which will be releasing, the arterial wall will be releasing the ANF, atrial natriuretic factor, by which the blood volume should be lowered down, or blood pressure should be lowered down. So how it will do? It will oppose the action of the RAS. So ANF inhibits the release of renin from JGA. So what does it do? This ANF, that atrial natriuretic factor, will inhibit the release of the renin from the JGA. So in the absence of renin, angiotensin will not be formed, and in the absence of angiotensin, again the blood pressure will be normal. Okay, so here the ANF inhibits the release of renin, due to which This will be inhibiting the reabsorption of sodium by the collecting duct, and also reduces the release of aldosterone from the adrenal gland. So altogether, this will be responsible for release of this will be responsible for inhibition of water absorption and sodium absorption, due to which the urination will be high, and the urine will be also containing the sodium ions. Okay, so during the urine will be also containing the sodium ions. Now that was about this ANF. So what ANF does, ANF will be functioning just opposite to RAS. So it will be inhibiting the ANF, it will be inhibiting the renin, and hence will be inhibiting the secretion of aldosterone, or we can say reduces the secretion of aldosterone, and hence the reabsorption of the water and the sodium from the PCT and DCT and collecting tubules will be decreased, and hence the urine will be having more water, and the sodium ions will be also present in that, and the blood volume will be decreased, and the blood pressure will also be decreased. So it will be functioning to opposite of the RAS. Okay, next is micturition. What is micturition? Okay, so micturition is a process. It's a simple process of voiding or removing or expulsion of urine which was stored in the urinary bladder, and this is called as micturition. So what is micturition? It's removal of urine which is stored in the urinary bladder. Okay, now urinary bladder gets gradually filled up with the urine. We know that when it would be gradually filled up. So when the urine is formed, that will be stored in the urinary bladder up to a particular period of time. We know that there are involuntary and voluntary muscles over there, sphincters are there, which will be regulating its opening, right? So though the capacity of urinary bladder is about 800 ml, although the capacity of urinary bladder is about 800 ml, but when around the volume of 500 ml is achieved, when it is filled around 500 ml, the walls of urinary bladder will start getting stretched. When it is filled around 500 ml, what will happen? Its wall of urinary bladder will start getting stretched. Now, due to the stretching, the urine which is formed by the nephrons is ultimately carried to urinary bladder. We know that the urine which is formed by the nephrons will be carried to the urinary bladder, where it is stored till a voluntary signals which will be stored there. It will be stored there till a voluntary signals which is initiated. So it will be stored up to what time it will be stored? It will be stored up to the time when the voluntary signals are basically received. And how these signals will be received? The signals will be received by the nervous system. How these signals are basically initiated? So these signals will be initiated by the stretching of walls. So what happens? The urinary bladders will be filled up with the urine. After a particular period of time, around more than 500 ml of urine is collected. So what will happen? It will stretch the wall. Due to this stretching, it will signal to the nervous system. The stretch receptors which is present on the wall will generate nerve impulse. That is carried by the sensory neuron to the brain, producing the sensation of fullness. Okay, so this stretch receptors which are present on the wall will be generating nerve impulse which is carried to the neurons, carried to the brain, producing the sensation of fullness. Okay, and then it will be responsible for urge to vacant the urinary bladder. Okay, how? So this whole impulse which is generated will be responsible for initiating the autonomic reflex. It will responsible to initiate the autonomic reflex, which is a part of parasympathetic nervous system. We'll see what is it. It's a part of parasympathetic nervous system, which is also involving a sacral spinal nerves, So due to this autonomic reflex, which will result in the contraction of the detrusor muscles. We have seen in the urinary bladder the different types of muscles. So detrusor muscles will be the muscle responsible for its contraction particularly. Okay, so it will be resulting in contraction of detrusor muscles of urinary bladder and inhibition of motor impulse of voluntary muscles. Now, so this will be responsible for inhibition of motor impulse of the striated external sphincter. So due to which the external sphincter will get relaxed and the urine can come out. Okay, so this is under regulation of autonomic reflex, which is again a part of a parasympathetic nervous system. So when the person is basically feeling this feeling the urge to remove the urine, the sphincters, the external sphincter particularly, will be its voluntary nature and will open up and will relax, and hence the urine will come out. That process is called as micturition. Okay. Next, composition of urine. So an adult human excretes on average 1 to 1.5 liter of urine per day. So an adult human excretes around 1 to 1.5 liter of urine per day, which consists of around most of the time it will be consisting of 96% of it will be consisting of water, 2% of water, urea. As we know, urea has to be in diluted form. So 96% will be water and 2% of urea, and other dissolved solids will be around 2%. Other dissolved solids will be around 2%. Okay. What will it will be consisting around? It will be consisting uric acid, which is derived from basically these are the ones which are present as a part of nitrogen waste. So the uric acid will be mainly derived from the nucleic acid metabolism, that is purine particularly. So the uric acid will be derived from the purine metabolism. Creatinine is also a type of amino acid, we can say, or type of biomolecule. It's a byproduct of muscle metabolism. It's a byproduct of the muscle metabolism. So muscle, when basically carried out different type of reactions, they will be releasing creatinine as a byproduct. Okay. Apart from this, the inorganic salts like chlorides, phosphate, oxalates, sodium, potassium, etc. There are different type of salts which are present in nitrogen wastes. Okay. And the urine is we can say characteristic of urine. So urine is transparent or sometimes pale yellow, and this yellow color is due to the urochrome. A particular component, or we can say breakdown product of a hemoglobin. So hemoglobin is the one you know what hemoglobin is red in color, right? So when it is broken down, it will be releasing a specific molecule, that is urochrome, which imparts the pale yellow color to the urine. Okay. Now urine is acidic in nature, and it also differs on depending on the dietary intake. So if you take lot of vegetables, it would be alkaline sometime, and if you take the high amount of fruits, it may be acidic. But normally it is acidic, around 6 pH it will be having. It will be having an unpleasant or ammoniacal smell. Unpleasant or ammoniacal smell will be present in this urine, and this is due to the conversion of urea into ammonia by microbial action. So when urine is released, so urine is present, so the urea which is present in urine will be converted into ammonia by the microbial action. Okay. Sometimes the abnormal constituents may be found in the urine. There may be some abnormal constituents may be found in the urine. That is, like suppose protein, mostly the albumin is found. When it can occur, when there is an injury in the urinary tract. Whenever there is an injury in a urinary tract, or we can say glomerulonephritis, which we can say the inflammation of nephrons, or we can say glomerulus, or we can say the injury to the renal tract may lead to presence of the proteins in the urine. Next, sometimes the urine may contain the bile salts. This is mainly found during the jaundice. So when a person is suffering from jaundice, the bile salts will be present in the blood and the lymph, and even the urine as well. In the person who is suffering from the diabetes mellitus, who is having the hyperglycemic condition, it means they will be having high concentration of glucose in the blood. So in that condition also, there may be the case where the glucose can be found in the blood. There may be the case where the glucose is found in the urine, which is abnormal in nature. And the ketone bodies are the one acetoacetic acids and beta hydrobutyric acids. These are the ketone functional, the molecules having ketone functional groups. So particularly these molecules are mainly found again in the case of person suffering from diabetes mellitus. And if the person is carrying out a prolonged fasting for a long duration, he's suffering from starvation, he's basically carrying out fasting. So under that condition also, the proteins may start utilizing, fats also get utilizing for the energy purpose. So during that condition, the ketone bodies are formed, and these ketone bodies are found in the blood and even in the urine also. These ketone bodies will be found in the urine, and that's again an abnormal condition. Creatinine, this is again a type of abnormal condition where the creatinine will be found in urine, mainly during the starvation. If person is starving from a long duration, then he or she may get the creatinine in the urine, and because the muscle breakdown particularly. And hyperthyroidism, again when the person is suffering from the disorder of thyroid gland, that is hyperthyroidism, in that case also the person may have the higher amount of creatinine, or there will be presence of creatinine in the urine. Okay, so this is all the composition of urine and the different abnormal condition of urine. Next is the disease of urinary tract. There are a lot of diseases related to the urinary tract. Let us see. First of all, nephritis. The name itself suggests it is the inflammation of the nephron. mainly due to the inflammation of the nephron. We can say inflammation of kidney, mainly due to the infection caused by bacteria, mainly due to the infection caused by the bacteria, mainly due to the infection caused by the bacteria. Next is glomerulonephritis. Inflammation of the glomeruli. It is the inflammation of the glomeruli. Okay. And then is pyelonephritis. Inflammation of the tissues, kidney in the pelvis region. We have seen pelvis region where it's just behind the hilum. Okay, where all the calyces will be opening up. Next is the cystitis. It's inflammation of the urinary bladder. So sometimes the cyst may be formed in the urinary bladder, and that may be called as cystitis. That may be considered as a disease of the urinary tract. Renal calculi, it's a formation or the presence of stone or insoluble mass of crystallized salts like oxalate within the kidney. So it's called renal calculi. That's a formation of insoluble mass of crystallized salt in the kidney that may cause a severe pain in the person and would be facing the problems while urination as well, and it will be causing the pain. Polyuria, it's amount of urine passed out is more. So normal, it's basically the more amount of urine compared to the normal. So that is mainly where the feedback mechanism or the regulation of the urine is not proper or it's lost. This condition may lead to the polyuria. Next is uremia. It's the concentration of urea is increased in the blood. So if the concentration of urea, the nitrogen waste, is increased in the blood, that condition is called as uremia. Alkoptonuria, it's a genetic disease. We will be studying in that genetic disorders as well, where the homogenetic acid is excreted out with urine. So along with the urine, it will be having homogenetic acid. And pyuria is the presence of pus in urine that will, again, due to the different type of infections may be present in the body, and that may lead to the formation of pus and releasing the pus along with the urine. Next is glycosuria, presence of glucose in urine. Mainly you have seen it is found in the diabetes mellitus condition. Hematuria, presence of blood in urine. It is again a type of very critical condition where the blood is secreted along with the urine. And the inulin is a fructose storage polysaccharide. We know it's a polysaccharide made up of fructose. It is not metabolized by human body, and we do not have any enzymes to metabolize the inulin. So, and is readily filtered through kidney. It is therefore used in testing kidney function. So this inulin it's important. Inulin is a fructose polysaccharide which is not metabolized by human body, and it will be easily filtered by the kidney. It is not basically retained by it will be easily filtered through the kidney, and therefore it is used as a testing the kidney function, especially the glomerular filtration rate. So we can test whether the kidney is functioning properly or not by inulin. Okay. And tubular maxima, the maximum amount of the substance that can be retained in blood and beyond which it will be excreted in urine is called as. So every substance has got a specific capacity in the blood. Okay, so if it is present in a higher amount, then it will be released through the urine. Okay, and that is called as tubular maxima. This is the maximum amount of any substance that can be retained in the blood. If it is higher, it may be drug, it may be any particular type of vitamin, it may be anything. So it may be released out in the form of urine. And next, and the last topic is the artificial kidney. Not last, but next to last. Artificial kidney, as name itself suggests, sometimes many times what may happen, the person may get the kidney damaged. Okay, so due to some specific problems, what may happen, the person may damage the kidney. So when the kidneys are completely damaged, if the one of the kidneys is damaged, still the person can survive properly. But if both the kidneys are totally damaged, 100% completely damaged and do not function, then the patient will be receiving the hemodialysis. Then the person will be receiving the hemodialysis, or we can say the treatment with an artificial kidney. Now, what does it mean? Hemodialysis is a separation of certain substance of blood. Okay, so we know that what actually the kidney do. Kidney separates the substances, that it separates the nitrogen waste from the blood. Okay, so it's important. Its function is so important. So the same thing is being done outside the body. So it's a separation of the certain substances. What all certain substances are? These are the nitrogen wastes. So it will be separating the certain substances from the blood by use of a selectively permeable membrane. What is it? Selective permeable membrane are those membranes which will be allowing the passage of only few molecules. And in this case, these few molecules will be this nitrogen wastes particularly. Okay. Now the pores in this membrane allow some substance to pass through. however prevent others. So as we've seen, they are selectively permeable. Okay. Now the patient is connected to the machine. Here you can see this machine. This is the machine. This is the patient. Okay. This patient will be. This is the hemodialysis machine. This patient is connected. This patient is connected to the machine by a tube attached to a artery. Often the radial artery is taken. So often the radial arteries will be taken. Okay, so that the blood can be easily flown. So it is connected to the radial artery. Okay, and blood from the artery is pumped into a tube. The blood to the artery is pumped into a tube. This is a tube. Okay, the blood from the artery is pumped into a tube that runs through a dialyzer. This is the dialyzer. This is the dialyzer. This whole setup is called as dialyzer. Okay, so this blood will now run through the dialyzer. The dialyzer is filled with a dialysis fluid. This dialyzer will be filled with a dialyzer fluid. This will be filled with a dialyzer fluid. We'll see what it is. So here we can say it will fill with a dialyzer fluid. The dialyzer is filled with dialysis fluid which contains the same quantity of electrolytes and nutrients as normal plasma but contains no waste products. So this fluid fresh dialysing solution is basically continuously given out over here, and this solution will be consisting, dialyzer will be consisting, it will be isotonic to the plasma. It will be isotonic to the plasma. Okay, so we know that plasma will be consisting different type of salts, and different type of salts will be present in different concentration. So this dialyzer will be having same concentration of all the salts. So we can say it's isotonic or almost similar to this plasma. Okay, but there will be one difference. That difference is that the dialyzer will not be containing the nitrogen waste. The dialyzer will not be containing any type of waste products. The dialyzer will not be containing any type of waste products. Are you getting it? So what we have done, we are collecting the tube blood from the artery, and this will be passed through a solution. This solution is basically dialyzer. Dialyzer is basically having the same concentration as the blood plasma, but without any waste product. Now the cellophane tube, a tube which is bounded by a thin membrane. So this is a cellophane tube, which is, now this tube will be wrapped by a thin membrane, Okay, and this membrane is over here, selective permeable membrane is kept in dialysis fluid. This cellophane tubes will be kept in the dialysis fluid. The pores of the cellophane tube do not allow the movement of blood cells and proteins from the blood into dialysis fluid. So the pores which are present on this cellophane tube, has got a specific size. That size is such a manner that it will not be allowing the movement of the blood cells which are present in the blood. So the blood cells and the proteins will not be moving outside the tube. Okay, but it will be allowing the smaller molecules to diffuse into the blood. So it will be not large enough to pass the blood cells, but it will not be small enough to prevent the passage of the small molecules, mainly the waste products. Okay. Now the molecules of waste substances such as urea, ammonia, and other waste will be diffusing into the dialysis fluid. As we seen, this dialysis fluid will be having all the solids which are present in the plasma except the waste. So now here the waste is present in blood. So blood will be having higher concentration of this waste. Okay, and this will be moving into the fluid which is having dialysis fluid, which is having no concentration of fluid. So we can say the waste will be moving from high concentration to low concentration by simple diffusion. Okay. So the molecules of waste substance such as urea, ammonia, and waste diffuses into the dialysis fluid. The diffusion of other substances such as glucose, amino acids, and electrolysis is prevented. How it is prevented? Because the glucose, amino acids, and all other substances will also be present in the dialysis fluid at same concentration. So when the concentration is the same, it is isotonic. So they will not pass from one place to another. Okay, so only the passage of the nitrogen waste will take place. Okay, now the blood is returned to the patient body. Through the radial vein. Now when the blood is taken out, it is cooled for a while, and it is mixed with anticoagulant. Why? Because if outside the body, it may get coagulated, and then the blood will not be able to return back. We cannot transfuse it again. Okay, so that may lead to different type of complexity, maybe death as well. So this has to be added with the anticoagulant and then pumped into artificial kidney. So when this blood pump is there, which is responsible for addition of anticoagulant and will respond to the movement of the blood outside this body. Okay, the blood coming out of the artificial kidney is warmed again. It will be warmed so that it can reach to the body temperature. And it will be warmed up to the body temperature and mixed with the antiheparin and returned to the vein. Okay, so this is what we are. Heparin is the anticoagulant, and when we add the antiheparin, it will be again functioning as a proper manner. Okay. Next, so that was about how the functional artificial kidney will be functioning. Let us see. So hemodialysis we have seen. The dialysis filled with some quantity of the electrolytes and nutrients as normal plasma we have seen. The cellophane tube is bounded with a thin membrane having a specific pore size by which it will preventing the movement of the blood cells and the different nutrients or the substances required, blood cells, proteins, all that. But it will be small enough to allow the passage of the waste products, particularly urea and all that, ammonia and all that, right? Now the molecules of only waste such as urea and ammonia will be moving from the blood to the dialysis fluid, because other fluid like glucose and amino acids, and they are not moving because the concentration of glucose, amino acids and all the solids will be same as that of blood, but the nitrogen waste will be not same. So nitrogen waste will be moving from high concentration to low concentration. Now the blood, when there is taken outside, it is basically taken from the radial artery. It is pumped with the anticoagulants and it is cooled for a while, and then it is mixed. It is moved to the dialysis solution. Then it is again moved into the. It is taken to the inside the body. So when it is pumped inside the body, it will be warmed for a while so that it can return to the body temperature, and then the antiheparin is also added, and then it is basically returned to the vein. That was about the artificial kidney. Okay. Sometime when both the kidneys are completely damaged, the kidney transplantation is done. So that is the kidney from one person can be transplanted to another person. But this transplantation can be done only when the histocompatibility complex are same. Or we can say the body has got a specific type of property by which it can recognize the self and non-self material. So if the body is recognizing the external kidney, the transplanted kidney as self, then only it can get successful. Otherwise the body may reject this kidney, and that may lead to different type of problems. Mainly can cause death as well. So the first kidney transplantation was done by David Hume at Joseph Kelly and in Boston particularly. And the receiver was Richard Herrick, who lived for around 8 years after transplantation successfully. And the first transplantation in India was done in Christian Medical College, Vellore. Okay. Now most patients need to be dialyzed before transplantation. So most patients need to be dialyzed before transplantation, so that the fluid overload and hyperlipemia to avoid this overload of fluid and hyperlipemia after the operation. So once the operation is done, the kidney should not be overloaded with the fluid. Okay, so before operating, the body has to go for hemodialysis, so it does not contain waste. Antibiotics and antibiotics, because when we are transplanting a different organ, so that organ may get infected by different type of organisms, and hence antibiotic has to be administered regularly. And immunosuppressive drugs are also given. Immunosuppressive drugs are those drugs which will be suppressing the immunity power of the receiver, because the immunity power or the immunity of the receiver body will be considering the transplant as an external organism or external structure, and hence it can reject it. So we can suppress this immunoactivity by providing some specific drugs, that is immunosuppressive drugs. Okay. And post-operative care is so important. So many times after the successful transplantation also the person may get some complications, because the immunity may work against the kidney which is transplanted. Okay, so this is something which is so important. Apart from kidney, there are some other organs also which are involved in the excretion. Apart from kidney, there are some other organs also which are responsible for excretion or removal of waste. First is the lungs. It removes the CO2 and water. CO2 is removed on around every day. Around 18 liters of CO2 will be released per hour. Okay, so around 18 liters of CO2 will be released from our body per hour, and about 400 ml of water will be released per day. This is basically metabolic water particularly. Okay. Next is the skin. Skin contains a large amount of sweat glands which are supplied with the blood capillaries. Okay, from which they will be excreting the sweat and some metabolic waste. Okay, metabolic water particularly, metabolic waste is as well. Now the skins will be releasing some sweat, and along with sweat they will be also releasing some some salts. Okay. Next is the sebaceous glands, which releases sebum, which contains wax, sterols, and some hydrocarbons and fatty acids. Okay. Liver, it produces the bile pigments, which are metabolic waste of hemoglobin and dead RBCs. So RBCs, when they are dead after 120 days of lifespan, they will be basically dying in the spleen. They will be producing the bile pigments. This has to be removed out. Okay, so this is removed in the form of and also elimination of the cholesterol, inactive products of steroid hormones, vitamins, etc. is done by liver. So liver will be responsible for detoxification. The drugs which we take, the alcohol which we take, and all these things will be basically detoxified and will be broken down into simpler form, and then it will be removed out through the liver, mainly through the fecal waste particularly. Okay, and maybe through the urine also, a very small amount. Okay, by very small amount, not much. Okay. Next is large intestine. The large intestine, the epithelial cells of large intestine secrete the ions like calcium, magnesium, ferrous into lumen, and which will be coming along with the fecal matter and removed out. Okay, that was about the excretion with the help of other organs. Okay, we can say accessory excretory organs. So that was all about the excretion. So what we are done with the type of excretion. Then we are done with the excretion organs. Okay, and then the structure of kidney, structure of nephron, and urine formation, how the urine formation is taking place, how it is regulated. Okay, auto-regulation. And then we have seen the regulation of kidney function, and then we have seen the different type of what you can say, the disorders related to kidney and artificial kidney we have seen, diseases which are related to kidney we have seen. Okay, so that was all about the excretion. In the next we will be starting with the new chapter. Okay, so that's all. Thank you. Have a nice day.